I'm going to talk about integrating snakebite research in the broader NTD and One Health agendas. And I'm going to share lessons that we've learned from Kenya. For this presentation, we'll briefly explain what neglected tropical diseases are, and I'll focus on the PC NTDs, or preventive chemotherapy NTDs. The overview of NTD policies in Kenya, and as we've lined them up with the WHO roadmaps and strategies. I'll also talk about the NTD program implementation in Kenya as a case study on how we've been able to integrate snakebite research activities and interventions within the Kenya NTD program and the Directorate of Livestock, and the limitations and challenges and sustainability for this program going forward. So neglected tropical diseases are a diverse group of 20 conditions which affect over 1 billion people worldwide. They are mainly infectious in nature. They're severely debilitating and disabling, and affect people who live in the poorest parts of the tropical regions. They often present with devastating health and socioeconomic consequences, and in turn, stigma. So a common feature amongst these NTDs, like I've mentioned before, they're diseases of poverty. They affect communities that often lack a political voice that adequately represent their needs. Their negligible presence in the global health agenda and research agenda leads to the underestimation of mortality, morbidity, and socioeconomic burden. I've mentioned that they're already associated with stigma, which in turn leads to social exclusion. They're characterized by limited resources for their prevention and control. But the good news is they can be controlled, eliminated, and eradicated with already available intervention, just that we need to upscale this and adequately resource mobilize. Here's a list of NTDs. I'm going to focus on the last 5, which include onco, schisto, trachoma, and lymphatic filariasis. These are also known as preventive chemotherapy NTDs. The list has been updated over the years to include non-infectious diseases like podoconiosis and snakebite, which is the reason why we are all here today. And the rest of my talk, I'll be sharing how we've been able to integrate snakebite with 3 of these PC NTDs in Kenya. Preventive chemotherapy is a major global strategy in the fight against neglected tropical diseases. It is defined as the large-scale delivery of safe and quality-assured medicines, either alone or in combination at regular intervals to mass populations. The World Health Organization recommends preventive chemotherapy against the 5 NTDs I earlier highlighted. Treatment involves mass drug administration of praziquantel for schisto, albendazole for soil-transmitted helminths, and ivermectin for lymphatic filariasis and onchocerciasis, and sometimes often in combination. In Kenya, we have these NTDs listed. We've been able to successfully eradicate guinea worm. The dossier is with the WHO, and we're waiting for validation. Targeted for elimination, we have the human African trypanosomiasis, leishmaniasis, lymphatic filariasis, rabies, schisto, STH, and trachoma. And targeted for disease control, because we cannot eliminate or eradicate them, we have dengue, hydatidosis, tiniasis, foodborne trematode, scabies, and snakebite is in that list as well. So I'll also briefly touch on an overview of NTD policies that have been we've adopted locally and that have enabled us to integrate because they talk about integration. Over the years, the WHO has been a major player in developing strategies and roadmaps to control neglected tropical diseases. They have provided set targets by which communities can work towards the control, elimination, and eradication for particular NTDs. The particular roadmap, very recent one, sets ambitious targets to control, eliminate, or eradicate NTDs for the period 21 to 2030, and moves away from the previous roadmap that was mostly heavy with disease-specific programming to an integrated approach that cuts across all these 20 NTDs. The WHO strategy on snakebite envenoming is highlighted here. The WHO encourages country ownership of these documents, and so the Kenya NTD program has adopted and set internal country targets that acknowledge the local context of comorbidity and co-endemicity of NTDs, resource mobilization, partnerships, and existing policy frameworks. So in the next couple of slides, I'm going to talk about the Neglected Tropical Diseases Program and how it's implemented in Kenya as a case study of how we can integrate snakebite with other NTDs. Here is a map of Kenya with the current prevalence of trachoma indicated. If you overlay this map with the distribution of the 5 PC NTDs I mentioned earlier, then one realizes that the distribution of snakebite cases reporting follows a similar pattern of co-endemicity. This offers us a unique platform for assessing snakebite burden and rolling out joint interventions. So with MDA, we're exploring 100% geographic coverage for snakebite burden assessments, complementary with other focal surveys that we are undertaking, other partners are undertaking, and hospital data as well. So what are the programmatic steps of the Neglected Tropical Diseases Program in Kenya? The program has rolled out a breaking transmission strategy, which is aimed at reducing the level of infection, both prevalence and intensity, to a point where it's no longer possible for the disease to be transmitted from one person to another. The focus is mostly on first mapping out where the diseases are present in the country. This is followed by annual mass drug administrations or the preventive chemotherapy of these NTDs through community health promoters, after which validation surveys to determine effectiveness of the MDAs are undertaken. The program has also established effective partnerships between NTD program and water, sanitation, and hygiene sectors, otherwise known as WASH. Implementation of behavior change communication is also a key intervention in the control of the 5 PCNTDs as well as other neglected tropical conditions. So we've developed our third NTD master plan that covers the next 5 years as part of our Kenya government's effort to ensure that NTDs are no longer neglected or associated with the poor, but are eliminated in Kenya. We are very ambitious towards achieving universal health coverage. So integration is going to be part and parcel of how we manage the NTDs in Kenya going forward. I will now highlight the opportunities available within the Kenya NTD program for integration of the various diseases that include snakebite, and these are epidemiological surveillance and disease mapping. We've integrated snakebite with other NTDs in the area of social mobilization and community health education, training and capacity building for health workers and community volunteers, management and care, such as counseling, reducing stigma, promotion of implementation of research and innovations, integrating planning, monitoring, and evaluation. In the next slide, I'm showing you a primary form that we use by community drug distributors to document. This is a case for trachoma mass drug administration with azithromycin. So I managed to convince our NTD program, Ministry of Health, and the support partners to include 2 snakebite questions in this form. And these were whether one had experienced a snakebite in the last 1 year, and 2, whether they attended a health facility or not after the bite. So if you look at this column here, you can see those 2 snakebite questions. So prior, we didn't have these two questions here, and it was purely used to collect trachoma data. The next form is used to summarize the treatments in a given location after the community drug distributors have collected their numbers at the end of the day. So snakebite summary statistics are also captured here, and we also disaggregate by male and female. So we're able to know in these populations how many males and how many females have suffered a snakebite incident. There are additional forms cascaded upward that capture the final tallies at the sub-county and county level, and this is finally reported to the National Ministry of Health. So some of the results we've been able to generate through this mass administration of the 3 preventive chemotherapy NTDs, we've been able to establish incidents in at least 17 counties in Kenya so far, covering a population of 13 million. This translates to at least 28% of the Kenya total population. So when we go to the communities, everyone who is administered with a drug, we get to ask them if they've suffered a snakebite in the last 1 year. So I think it's an effective way of really getting to determine baseline data and working towards the reduction of this number. You can clearly see the red here indicates incidence above 250, quite high. Tallies with the hospital data statistics as well, and some regions with the average, you could term, statistics. These statistics are very valuable to our Ministry of Health because unlike in the previous years where quality epidemiological burden of snakebite was hard to come by, we now have reliable estimates that can be used to assess the burden of snakebite in the country, appropriately distribute antivenom vials, depending on need, and establish snakebite hotspots with need for targeted intervention. One of the questions was asking the respondents whether they'd attended a health facility or not. And here you can see that a lot more people were reporting that they didn't attend the health facilities as compared to the data that we're getting from the health facility records. So we're able to really clearly show, and this is consistent with what is already being reported elsewhere, that a percentage of snakebite victims do not attend health facilities, and thus we can now appropriately up our BCC community engagement and encourage communities to attend health facilities whenever they experience a snakebite. This part of our social mobilization and community health organization. Professor Yimka here, my co-director, attended one of our mass drug administration exercises. She took the azithromycin tablets. So this picture really captures the social mobilization and community engagement in northern Kenya. It's really important that the community leaders participate in these activities like shown here, because then now the communities also uptake the activities without much pushback, and also provide the information that we request from them very easily. I was conducting healthcare worker training here and advocacy and sensitization in the Lake Belt region of Kenya to integrate snakebite with the schistosomiasis and soil-transmitted helminths. And this next picture captures the training of healthcare workers just to advocate for the need to capture data on snake bites. This document here captures the management of snake bites. We're able to borrow a lot from other NTDs, and not just NTDs, malaria as well, where we're encouraging communities to sleep under bed nets. It's been documented elsewhere to reduce snakebite cases. And with the Directorate of Livestock, we've been able to again, I convinced them to include a snakebite question there. So other diseases are all combined together, and Kenya has been suffering droughts for the last 3 or 4 years. So we were keen on knowing how many livestock we are losing through droughts, and we have snakebite here as well, and floods. So really here we want to know, the government would like to know what is the socioeconomic loss or burden arising from snake bites in livestock. This is also a census ongoing in all regions of the country, and the data is still very preliminary. So hopefully the next time we meet, I'll be able to share a comprehensive data set. We face some challenges and limitations as we integrate. We've had issues with coverage where certain communities push back and don't want to take the drugs. And so while that is happening, we also can't collect data on snakebite, access, wash issues, adherence with the drugs, and incentive for community distributors. They've been volunteers in the past, but now with the increased duties, they're demanding to be paid. Logistical issues of distributing the drugs to every member of the community across the country is never easy. Issues with stigma that we face with NTDs, and certain groups of people are likely to be missed. Elderly persons who, for example, when you're conducting an MDA or administering drugs in a focal point, are not able to leave their households to get to those regions. Youths who sometimes wander off as they take care of the livestock. Children who go to school, men in some communities who are mostly fishermen, so they're out fishing in the lakes, and people with disabilities. Certain specific disease nuances also prevent us from integrating and just managing partnership expectations. Some partners feel that when you're integrating with a new disease, you might overshadow the primary disease focus. And so we've always tried to manage this through just talking. And conflict areas that have one of the biggest challenges that we face as we are integrating NTDs with snakebite with other NTDs. This picture clearly shows that. So this is Turkana County. We were able to only assess the 3 sub-counties. The rest of the sub-counties, we don't have any data on them, and this is because of conflict, insecurity issues in those areas, so we couldn't go, as opposed to Kilifi County, towards the coastal region of Kenya, where we're able to map the whole area. So in summary, there are key similarities between snakebite with other NTDs. This forms a basis of underlying it forms the basis that we can assess burden of snake bites in joint ventures with other NTDs. We can influence and effect, the influence and effect on poverty and development is also a common theme across these NTDs, and the neglect. So overall, what I really think is if we strengthen the health capacity, the health systems, we can create a perfect platform of integrating these NTDs and getting the data that we need, leading to appropriate interventions. Beno, I tried to include a question in here. If people, I don't know if I put it rightly, can identify opportunities of integration in their own countries. Lastly, I would like to thank that picture, our hardworking community health promoters or volunteers who enable this work, because they reach out to every member of the community, the Kenya NTD program, LSTM, the funders and partners of this work, and finally BNITM for availing this platform to share this data. Thank you.